This talk will provide a broad overview of cardiac transplantation. This is an overview of the lecture agenda, where we will review important historical aspects of cardiac transplantation, current relevant epidemiology, issues pertinent to donor and recipient selection, technical aspects of the donor heart recovery as well as implant procedures, updates with respect to rejection diagnosis and treatment, and contemporary outcomes. Dr. Shumway and Lauer pioneered the techniques that ushered in the era of cardiac transplantation. The first human heart transplant was performed in Cape Town, South Africa, by Dr. Christian Barnard on December 3, 1967. The advent of endomyocardial biopsy for rejection surveillance and advanced immune suppression regimens, including cyclosporin, have led to improved long-term survival rates. End-stage heart failure is a serious problem in the United States and worldwide, with an estimated 5.7 million affected individuals in the U.S. Congestive heart failure is the primary cause for nearly 1 million hospital admissions in the United States each year, and the most common reason for patients above age 65 to be hospitalized. Congestive heart failure is more prevalent than the three most commonly occurring cancers. There are many etiologies for advanced heart failure, and the most common cause is ischemic cardiomyopathy. Approximately 20% of patients will die within 1 year from diagnosis, and CHF accounts for roughly 300,000 deaths in the United States annually. There are increasing mortality rates with greater severity in New York Heart Classification. The number of heart transplants performed in North America has remained relatively constant over the last decade, with approximately 2,200 transplants each year. Idiopathic cardiomyopathy, shown in yellow, and ischemic cardiomyopathy, shown in red, constitute the two most common etiologies for heart failure requiring transplant. Other less common etiologies include severe valvular disease, congenital anomalies, viral syndromes, postpartum cardiomyopathy, adriamycin toxicity, and prior allografts. The percentage of patients undergoing transplant with ventricular assist devices in place has remained relatively constant since 2001. However, the relative number of patients supported as a bridge to transplant with continuous flow devices has increased since the FDA approval in 2008 of the HeartMate 2 device for use in bridge to transplant. Prior to undergoing heart transplant, many patients with congestive heart failure will have undergone prior cardiac operations, including coronary artery bypass and valvular procedures. Furthermore, there are specialized procedures specifically aimed at the failing heart in selected patients, including cardiac resynchronization therapy, ventricular remodeling, the application of passive restraint devices, and the use of ventricular assist devices. However, in appropriately selected patients with end-stage heart failure, refractory to medical and these alternative surgical therapies, heart transplant remains the gold standard therapy. Patients selected for cardiac transplantation should have irreversible and debilitating cardiac disease, despite maximal therapy, without alternative medical or surgical treatments. Patients should generally also have relatively low pulmonary vascular resistance, as high fixed pulmonary vascular resistance can impair early allograft function. As well, given the psychologic and physical stressors that the patient will encounter in the postoperative period, it is imperative that a thorough social evaluation be performed in order to identify patients at risk for poor compliance. Patients with active systemic infection should not be listed for cardiac transplant. Patients with localized infection, such as driveline infections related to VAD use, may be considered for transplantation. In addition, those patients with irreversible liver or kidney impairment should not be listed for isolated cardiac transplant. In selected cases, simultaneous multi-organ transplant may be considered. Unresolved recent cancer is also a contraindication to transplant. Finally, patients with severe fixed pulmonary hypertension should be considered for heart-lung transplant. There remains a significant shortage of donor hearts, and as a result, 10 to 20% of patients on the waiting list will die before receiving an allograft. The allocation of organs is determined according to recipient priority, length of time on the waiting list, and proximity of the donor organ. The system is designed to provide organs to the most acutely ill while minimizing organ ischemic time. Status 1B patients are those patients who have a mechanical circulatory assist device for longer than 30 days, and also those patients who are requiring continuous intravenous inotropes. All other heart transplant candidates are listed as Status 2. The screening evaluation of potential donors is rigorous and typically initiated by the local procurement agency. It is important to ascertain that the donor heart is structurally normal and has well-preserved function. Catheterization should be performed in select cases, typically if the donor is older than 50, has risk factors for atherosclerotic heart disease, such as diabetes, tobacco history, or a significant family history. The recovering surgeon should examine the organ for evidence of myocardial infarction, coronary atherosclerosis, or myocardial contusion. Use of low-dose inotropes is acceptable, but potential donors requiring higher doses of hemodynamic support should not be used. Donor age should typically be less than 55 years, although older donors can be used in select situations. Serologies for infectious diseases should be obtained, and donors with prolonged exposure to CPR, bacteremia, malignancy, and a history of cardiac trauma should not be used. The current average donor age worldwide is approximately 30 years, with very few donors above the age of 60. Blood group matching and donor-recipient size matching are the two primary concerns when allocating organs. ABO incompatibility generally precludes use of the organ because of the risk of fatal hyperacute rejection. Donor weight should be within 20 to 30% of the recipient's weight. In the setting of elevated pulmonary resistance, a larger donor should be considered. A panel reactive antibody level is still obtained in all patients, although broader application of virtual cross-matching may decrease the relevance of PRA in the future. Because of logistics, prospective cross-match cannot be performed in all patients, although those patients with PRA greater than 15% should have a negative prospective cross-match. Retrospective cross-matching is performed in all patients, even those with absent PRA activity. Generally, an organ with an expected ischemic time greater than 6 hours should not be used. Previously, there was no good standardized risk score to ascertain recipient risk in heart transplant, akin to the lung allocation score in lung transplantation. The recently published Impact Risk Index was generated using UNOS data and is an easy-to-calculate 50-point score comprised of 12 recipient variables. The risk index is highly correlated with one-year mortality and can be used to assess recipient risk at the bedside and also be used for risk stratification in research studies. Proper donor heart preservation is critical to ensuring good allograft function. Preservation is commonly performed using hypothermic storage with a single flush solution. Despite significant advances in cardiac allograft preservation, the optimal preservative solution remains unknown, although many different solutions exist. A recent retrospective study suggested that University of Wisconsin or Viaspan solution may have superior outcomes. The fundamental principles of donor heart preservation include arresting the heart, maintaining the heart decompressed, flushing the vasculature until effluent draining from the coronary sinus is clear, and preserving the appropriate structures during excision, followed by package in a hypothermic storage solution. The donor heart recovery is begun with a median sternotomy incision. After identification of the innominate vein, the pericardium is opened widely. The heart is then inspected. At this point, if the organ looks acceptable for transplantation, the recovering surgeon generally notifies the implanting surgeon of the organ's suitability. The dissection to mobilize the heart for cardiectomy then begins. The SVC and IVC are each separately encircled. The window between the aorta and pulmonary artery is dissected free. At this point, if the abdominal organs are adequately prepared, the patient is systemically heparinized. A purse string suture is placed in the ascending aorta to accommodate antegrade cardioplegia. The diagram on this slide reflects the setup of cannulas if the heart and lungs will be recovered separately, with a pulmonary artery cannula in place to flush the pulmonary vasculature. Upon confirming that the abdominal team is ready to proceed with organ recovery, the SVC is ligated distal to the azygous vein. The heart is vented via division of the left atrial appendage and also by incision of the anterior IVC. The heart is allowed to eject 2 to 3 contractions into the surgical field, and then the aortic cross-clamp is applied on the ascending aorta. Cold cardioplegia solution is then infused into the aortic root through the antegrade cardioplegia line. Once the heart is arrested and several applications of cold topical saline with ice have been placed on the exterior surface of the heart, the cardiectomy proceeds by completing the division of the IVC. The apex of the heart is then elevated, and working from the inferior to superior direction, the pulmonary veins and arteries are divided, paying special attention to preserve an appropriate size left atrial cuff. The ascending aorta and the SVC are the final structures to be divided. Following explant, the donor allograft is inspected on the back table prior to packaging. The presence of vascular anomalies, a patent foramen ovale, and valvular abnormalities should be assessed. The heart is then packaged in sterile bags, surrounded by ice and saline for hypothermic transport. Once the recovering team has confirmed the acceptability of the donor organ, the recipient is prepared for implant of the allograft via a median sternotomy and wide pericardiotomy. Bicaval cannulation is routinely performed, and the aortic cannulation site is generally just proximal to the innominate artery. When the donor heart has arrived, the recipient cardiectomy is completed. The majority of orthotopic heart transplants in the United States are now performed using the bicaval technique. However, in instances where a biatrial anastomosis is necessary, a right atrial cuff can be maintained, as is shown in this diagram. The implant of the allograft begins with the left atrial anastomosis in an end-to-end fashion. This is typically performed with a running, double-armed 4-row proline stitch, beginning near the recipient left superior pulmonary vein and traveling first in the caudal and medial direction. When performing the left atrial anastomosis, it is important to repeatedly assess for a size discrepancy between the donor and recipient atria and make any corrections as necessary. Prior to securing the left atrial suture, de-airing maneuvers are performed. In the bicaval technique, as shown in this diagram, the IVC anastomosis is next completed, again in an end-to-end fashion with a running 4-row proline suture. The SVC anastomosis is performed next, and some surgeons lock the posterior aspect of this anastomosis in order to lessen the chance of creating a purse string in the anastomosis. These diagrams depict the biatrial technique, but are presented to illustrate the aortic and pulmonary artery anastomoses. The pulmonary artery anastomosis is completed, again in a running fashion. It is important to trim the pulmonary artery length appropriately to avoid any kinking in this vessel as shown in the drawing. The perfusionist should begin to rewarm the patient at this juncture. The aortic anastomosis is completed last, and it is important to assure appropriate recipient donor size matching of the aorta. Extensive de-airing maneuvers are performed, including placing an aortic root vent and use of steep Trendelenburg. The aid of intraoperative TEE can also help visualize remaining intracardiac air. This illustration depicts the completed suture lines following the bicaval implant technique. This technique is increasingly performed in the United States according to National Registry data, and large retrospective studies suggest less need for pacemaker implant, shorter hospital length of stay, and a possible survival benefit. The initial orthotopic heart transplant technique performed by Dr. Shumway and Lauer used a biatrial anastomosis, in which an incision is extended from the orifice of the inferior vena cava in the direction of the right atrial appendage, and then a running suture line is performed, similar to the left atrial anastomosis. As mentioned before, many centers favor the bicaval over the biatrial technique, except in select situations. Currently, there are different pharmacologic regimens used by different transplant centers, but the basic strategies remain the same. Most heart transplant recipients are maintained on triple drug immune suppression regimens, with higher dosing in the first 3 to 6 months, because that is the period when immune reactivity and susceptibility for rejection are the highest. Over time, drug dosing can be tapered. Most immune suppression regimens consist of an agent that blockades the interleukin-2 pathway, such as the calcineurin inhibitors tacrolimus or cyclosporin, an antimetabolite such as mycophenolate or azathioprine, and despite their myriad deleterious side effects, low-dose oral steroids are part of the mainstay of immune suppression regimens. The benefits of induction therapy in the operating room remain controversial, and this practice is not routinely recommended. Virtually all cardiac transplant programs routinely use endomyocardial biopsy for routine surveillance of the allograft. While there are widely variable surveillance programs, most centers perform an initial biopsy on or near postoperative day 7. There is a tendency toward more frequent biopsies in the first year after transplant, with less frequent use the farther removed the patient is from transplantation. Endomyocardial biopsy generally samples right ventricular tissue and can be performed via the right internal jugular or femoral vein. The complication rate associated with biopsy is 1 to 2%, and damage to the tricuspid valve remains the major concern. Acute rejection is a normal immunologic host response to foreign cells, and between 30 to 50% of all heart transplant recipients will experience an acute rejection episode in the first post-transplant year. Acute rejection may be predominantly cellular-mediated, antibody-mediated, or a combination of both varieties. The majority of episodes of acute cellular rejection can be treated with pulse-dose steroids only. In contrast, antibody-mediated rejection is a less common and more difficult entity to treat. This table summarizes the recent ISHLT standardized acute cellular rejection grading system from 2004. This grading system is based on biopsy results, and the corollary labeling from the original definition is shown on the right side of the slide. No histologic evidence of rejection is labeled grade 0. The presence of an interstitial or perivascular cellular infiltrate with up to one focus of myocyte damage is labeled grade R in the updated 2004 consensus definition. The R labeling stands for revised to signify the updated terminology. 2 or more foci of infiltrate with associated myocyte damage signifies grade 2R cellular rejection. Grade 3R, or severe acute cellular rejection, is defined by the presence of diffuse cellular infiltrates with multiple foci of myocyte damage, with or without the presence of edema, hemorrhage, or vasculitis. While there are subtle variations in the surveillance and treatment of cellular rejection, in general, patients with grade 1R rejection on surveillance biopsy who have normal hemodynamics are simply observed. Patients with grade 1R who manifest hemodynamic impairment are treated with a regimen of pulse dose oral or intravenous steroids. Patients who develop grade 2R rejection with normal hemodynamics are also treated with pulse dose IV or in select cases oral steroids. Patients who exhibit grade 3R rejection on a biopsy specimen are generally treated with antithymocyte globulin. Also, patients with grade 2R with hemodynamic impairment and any patient with steroid-resistant rejection are treated with antithymocyte globulin. Maintenance immunosuppression regimens are generally continued at pre-rejection doses, provided serum levels are in the therapeutic range. Many centers perform a follow-up biopsy 1 to 2 weeks after treatment to document histologic resolution. Refined laboratory techniques have greatly facilitated the ability to detect acute antibody-mediated rejection. Accordingly, this entity has been formally incorporated in the revised 2004 ISHLT guidelines for rejection diagnosis and management. AMR 0 indicates no histologic or immunopathologic features of AMR. AMR 1 signifies a biopsy specimen that is positive for AMR, either according to histologic features or based on positive immunofluorescence or immunoperoxidase staining. A high-power image of AMR is shown at the left-hand side of the slide, with the characteristic myocardial capillary injury and endothelial cell swelling. The immunostain on the right shows the requisite immunoglobulin G accumulation and complement deposition. There are no consensus approaches to the treatment of antibody-mediated rejection. However, most centers treat AMR regardless of hemodynamic changes, because this entity is associated with worse long-term graft survival. One approach to the treatment of AMR involves use of high-dose IV steroids, plasmapheresis, intravenous immunoglobulins, and consideration to use of an anti-lymphocyte antibody such as rituximab. These survival curves are adopted from the ISHLT registry and reflect cumulative survival across 3 different eras. There is a statistically significant time trend, suggesting that a combination of improved surgical and anesthetic techniques, better perioperative care, and enhanced rejection surveillance and treatment may be contributing to improved patient outcomes. Overall, median survival after heart transplant is 10 years. Cardiac allograft vasculopathy, or CAV, is a significant source of morbidity and mortality among late survivors after heart transplant. Because the allograft remains deinnervated, many patients do not experience the classic symptoms of angina pectoris, and therefore this disorder is associated with an insidious onset. Both immunologic and non-immunologic factors are believed to contribute to its pathogenesis. Histologically, CAV is characterized by diffuse concentric intimal hyperplasia with smooth muscle cell and macrophage infiltration. In contrast to traditional atherosclerotic lesions, which are typically focal in nature, CAV is associated with narrowing along the entire course of the vessel, as shown in this coronary angiogram. CAV is difficult to diagnose and to treat, and is the leading cause for retransplant among prior heart transplant recipients. Operative mortality after heart transplant remains 5%, and this slide summarizes the primary causes of death within 30 days. Primary allograft dysfunction is the most common cause of early death, followed by multisystem organ failure and infection. Between 30 days and 1 year, infection poses the greatest risk of death. This is due to the high doses of immune suppression that are required in the first year. Graft failure, rejection, and multisystem organ failure are other common causes of death in the first transplant year. Among long-term survivors, the two most common causes of death are cardiac allograft vasculopathy and non-skin-related malignancy. Infection and graft failure are also frequent causes of death among patients who have survived 5 years post-transplant. In the nearly 45 years that have elapsed since the first human heart transplant was performed in Cape Town, South Africa, great progress has been made in the care of patients with end-stage heart failure requiring transplantation. However, there are many areas in cardiac transplant that remain rich areas for scientific research, such as improved organ preservation techniques, advances in immunosuppression agents, gene manipulation in an effort to achieve allograft tolerance, and also xenotransplantation. I'd like to acknowledge the following individuals for their support, and would also like to highlight the following resources which were used in compiling this lecture and may provide useful as supplemental reading.